Good afternoon, everybody. Let's
Good afternoon, sir.
Good
yeah,
afternoon, sir.
let's do the systems check. Am I visible? Am I audible? And is my shared slide visible to you?
Yes, sir.
Okay, good, good. So, how was your Diwali vacation? Enjoyed?
Yes, sir.
Lots of sweets to
Yes,
have.
sir.
Lots
No,
of
sir.
no. You didn't eat sweets, or you didn't enjoy?
So we were giving test.
Test was just for a small time, wasn't it?
No, sir.
No. So, how was the
Yes,
test?
sir.
Yeah, see, I getting contradictory reports. One says no, sir. One says yes, sir. That means some people are happy, some people are not happy. Some people enjoyed, some people didn't enjoy holidays.
But
So
not
let's
happy with that holiday. Only two
not happy
days.
with holiday. How you been having holidays since last 6 months, isn't it?
No,
Since
sir.
March. Since March 23rd, you are on holidays. No? No, too many holidays. Too many holidays will take you off the track. So let's keep you on track. Unfortunately, this particular pandemic has forced us to resort to this kind of a teaching. I don't really enjoy because having you people in front and talking to you, discussing things is much more fun than just hoping that you all are listening to me. Hoping. I don't know whether you people really listen to or you just log in and then wander off somewhere else to watch some TV. Do you?
So we do listen.
So we listen.
You listen. Okay, good. So, did you find the test interesting?
Yes, sir.
Was it challenging? Did it stimulate you to think and to find out answers from various places and compile them? We, if it is an online test, we believe in open book, open web system where you are free to locate the resources. The idea is not to cram the things. The idea is to have some concept in your mind and to be able to find out the reasons and to justify as to what line of a diagnosis or treatment or management you would like to follow. So that is the idea of OBOW. Otherwise, most of the tests are bookish tests where you are required to cram up some facts and pour it out without really understanding them. I prefer OBOW to be a better test. Well, so we had some MCQs, we had some PVQs. I hope you have found right answers to PVQs also, and you realize what answers you missed out wherever. We'll be giving you feedback on your replies. So wait for a while because we are right now evaluating the fourth semester block test, and thereafter we'll evaluate your block test also. Meanwhile, we'll progress to another system. I think you already have started with some classes of respiratory system. Have you?
Yes, sir.
Yes,
Okay,
sir.
good. So we'll carry on from there onwards. So do you see something on your screen? What is it? How do you interpret this? Anyone? Is it a geographic feature or is it a microscopic picture? Or is it just an imagination? What do you think it is? I had clicked this picture when I had gone from Jomsom to the nearby village, Marfa, en route. This was a feature where there is a huge mountain in the rear with some small shrubs on it, and this windswept hill, which has become more like canyons because of the erosion, water, and air erosion. It looked beautiful at that time, so I clicked it. The photograph doesn't seem to be doing justice to actual one, but it looks also to me something like an epithelial cell with some some villi or something projecting out of it. So we will now look at some of the other features of this particular class, and that is we are going to talk about sniffle, sneeze, and cough. Sniffle, sneeze, and cough are representative of the commonest symptoms of respiratory tract involvement, or it gives us a clue. If someone sniffles or someone sneezes or someone coughs, it gives us a clue, an indication that there is something happening with the respiratory tree, with the respiratory tract. And we will be looking at these, but these are not the symptoms and signs of respiratory tract diseases. There are many more. This is just a tip of the iceberg. So let's look at many other conditions. First and foremost, I'm sure the anatomists must have talked to you about it. So must have been physiologists. But just to recapitulate, that the respiratory tract starts right from the nasal cavity, involving the nose, the pharynx, the oral cavity, the sinuses, which are called as paranasal sinuses because they are on either sides of the nasal cavity, larynx, and then from there downwards as the bronchus, bronchi, bronchioles, terminal bronchioles, and then alveoli, surrounded by a layer of pleura. So the whole thing is a respiratory tract. That means a tract where the air enters from the environment and from where the air exits is called as a respiratory tract. Technically, we divide it into upper and lower respiratory tract for two reasons. The structural arrangement of the upper respiratory tract is very different from that of the lower respiratory tract, and two, the functions performed by both are also different, and therefore the diseases or the infections of the upper respiratory tract and those of the lower respiratory tract manifest differently. It does not necessarily mean that the infectious agents of the upper respiratory tract and lower respiratory tract are different. No, they may be same, but depending on the location where they are, the clinical features will be very, very different. So we'll be talking in two terms: upper respiratory tract infection starting from nasal cavity up to larynx, including larynx, and lower respiratory tract, which below larynx, starting with trachea right up to the alveoli, and also involving the pleural layer which surrounds the lungs. Here are some of the respiratory sinuses: frontal sinus, sphenoidal sinus, ethmoidal sinus, and maxillary sinus. They are named so based on their location because they are in the maxilla or in the ethmoid bone or in the frontal bone or sphenoid. And these are mirror images. That means one side of the sinuses are more or less mirror images of the other side, more or less, not exact, because some amount of deviations, some amount of differences do occur between the two. All the sinuses are lined by one particular type of epithelial cells, and therefore behavior of all the infections of these sinuses is more or less similar. Why do we need these sinuses? Does anyone know what functions these sinuses perform in our body? Anyone? Have you ever thought, why are there these cavities inside the bones making sinuses? If there were no cavities, there won't have been any sinuses. Yes, someone wants to say, what functions do these sinuses perform in our body?
They make skull lighter.
But we are not going to fly, so why do we have to make the skull lighter?
For voice,
For
resonance of voice.
ear resonance of voice, yes, but that's not the primary aim with which the sinuses were created.
For humidifying the inhaled air.
Yes, for, you can say, for modulation of the temperature and humidity of the inhaled air. That is a primary and the firstmost function of the sinuses. In addition to that, then because of their presence, when we make noise, when we voice our voice, we can create resonance, we can create heavy tone, or we can create light tone, or when nasal sinuses are involved, our voice gets changed. All those things are secondary to that. The primary function is changing or making the inhaled air compatible with the lower respiratory tract. So in this particular class of introduction, we'll see what are the general principles of pathogenesis of respiratory tract infection. We are not going to talk about individual infection right now, but we are going to look at a group of respiratory tract infections, either as upper respiratory tract infection or lower respiratory tract infection, and see what is the basis of their pathogenesis. Now, a pathogenesis of an infectious agent depends to a great extent upon what are the host defenses which are going to oppose that particular or modulate or change or influence infectious agent in that particular location. So we'll look at the host defenses of upper and lower respiratory tract, and then we will look at the agents which can cause upper or lower respiratory tract infection. But as I mentioned earlier, it is not that that an agent which causes upper tract infection will not cause lower tract infection. It can, and it will, and under different circumstances, it will manifest differently. So let's first look at the clinical conditions. If a patient gets upper respiratory tract infection, what do we expect the patient to suffer from, or what do we call these clinical conditions? These names are primarily based on the anatomical site which is involved, and since most of the infections will lead to inflammation, they are suffused with itis. So when we have an infection of the nose, we call it rhinitis, of the sinuses, sinusitis, so forth, goes to pharynx, epiglottis, larynx, tonsils, and adjoining cervical lymph nodes. Otitis media. Now, ear is not actually part of respiratory system, but it's connected by a tube with the respiratory tract. Yeah, Ritika, can you mute your mic, please? Yeah, thank you. That was good music, but we'll right now concentrate on the class. Listen to the music later on. So, otitis media, though the infection of the middle ear, not truly speaking a part of the respiratory tree, but is connected with the respiratory tree by one particular tube. What is that tube called?
Auditory canal.
The tube, name of the tube.
Eustachian tube.
Eustachian tube.
Eustachian tube. Very good. So Eustachian tube, since it connects with the ear, therefore ear involvement also is common in respiratory tract infection. Many times it influences the hearing ability also, and the infection from the respiratory tract can spread into the ear also. Therefore, you will find many times the agents which cause otitis media are more or less same which are found in the upper respiratory tract. Why have I included conjunctivitis over here? Conjunctivitis is not part of the respiratory tract, but if you have noticed, before you get common cold or during when you get common cold, you find there is irritation in the eyes. You feel like rubbing your eyes. You find some discomfort in your eyes, and eyes also become red. That also happens because there is a connection between the conjunctiva and the nose through anyone can tell us the name of the tube?
Nasolacrimal duct.
Nasolacrimal duct. So, like in otitis media, infection can go into the ear. Similarly, the infective agent can move from the nose right into the conjunctiva, or from above downwards as well, from conjunctiva into the respiratory tract also. Therefore, you'll find that many times when we ask people to protect themselves from contamination and respiratory tract infection, we not only ask them to wear mask which covers nose and mouth, but also wear eye protection, because sometimes the organism can get lodged onto the conjunctiva and may travel from there into the throat and can cause respiratory infection. And that's one of the reasons why in coronavirus pandemic you see most of the people having a face shield which protects their eyes, or wearing eye protective glasses whenever they are handling the patients. Gingiva and is not really part of respiratory tree, but since it is in the oral cavity, sometimes the respiratory tract infections can influence and can manifest primarily on the gums or on the palate, and therefore we will include that also as part of the respiratory tree, but not really playing big role in infections as such. These infections of different places require to be identified, because not only they tell us an anatomical the infection, but by clinical features it also tells us what type of an infection it might be occurring. We'll see about those a little later. Similarly, the infections of different components of the lower respiratory tract are also divided into tracheitis, bronchitis, bronchiolitis, pneumonias, interstitial pneumonias, that is pneumonia other than that of alveoli. So it is looked at separately from not alveolitis but interstitial pneumonia, lung abscess, emphysema, and then going to the periphery, involvement of the pleural cavity called as pleuritis, or if there is a fluid collection between the two layers of the pleura, then it's called pleural effusion. Most of these conditions, tracheitis right up to lung abscess and emphysema, are commonly manifestation with one symptom, that is cough. But cough in itself has got various varieties. Like fever has got varieties of fever. During ICM studies, you must have realized that there could be continuous fever, there could be intermittent fever, there could be step ladder fever, there could be fever with rigors and chills, low grade fever, high grade fever. Similarly, the cough of the respiratory tract infection, starting from tracheitis to emphysema, varies in its manifestation. And if you are observant enough, if your ears are trained well enough, just by listening to the coughing sound of the patient, you can make an anatomical diagnosis. Imagine, you just need to be paying attention to what you hear, paying attention to your stethoscope if you have, and just by listening to the sounds associated with cough, or the quality of cough, or the duration of cough, or the intensity of the cough, you can make out whether the patient is having tracheitis, bronchitis, bronchiolitis, pneumonia, interstitial pneumonia, lung abscess, or even emphysema. That is a clinical expertise which you need to develop. So what I would suggest is, there are beautiful sites available on the net where different respiratory sounds tracks are available. I'll suggest all of you to visit those sites, maybe download if they are downloadable, or Put on earphones, good quality earphones, and try and listen to those sounds. And try to differentiate one type of sound from the other. It's not easy. It takes time. It takes patience. It takes a lot of practice for you to understand it. But if you do that, then what will happen is that you will be able to diagnose your patients just by clinical examination. And if you can make an anatomical diagnosis, whether it is tracheitis or pneumonia or interstitial pneumonia, 99% of the times you will also be able to predict which is the most likely organism causing this disease. And if you can predict that, then empirically in 99 out of 100% cases, you will be able to give appropriate treatment. To give antibiotics or not to give antibiotic. Which type of antibiotic, how much doses, how much duration. In other words, just by paying attention to what you hear when the patient coughs or by putting stethoscope on patient's chest, you can have complete diagnosis, treatment, management with you. You don't really require most of the laboratory investigations. No X-rays, no ultrasound, no CT scans. They may be required in maybe about 5% of the cases. But 95% of the cases, you will be able to diagnose and treat them. This is what is required in our country. This is what is required for our society, where neither the investigations are available, nor are they affordable to majority of the patients. Your clinical acumen is what is going to make a difference in their life. You ask someone to get an X-ray done, it costs 500 rupees. Plus 200 rupees to go by the car, by the taxi, 200 rupees to go again to collect the report. 1000 rupees gone. And with that, what you are going to say is, oh, I had suspected pneumonia and look, X-ray showing pneumonia. You are very happy. But the patient feels, if you already knew it is going to be pneumonia, why did you ask me to get an X-ray done and spend my 1000 rupees? So you need to develop clinical acumen, and for that you need to listen to the respiratory sounds and the symptoms of the patient. Interestingly, pleural effusion is a condition where there is very minimal cough or no cough at all. The symptoms might be entirely different. And it's not only cough which is the symptom of all of these. The symptoms could depend on another important part which is a basic function of respiratory tract, is oxygen saturation or air exchange. So the patients may manifest with symptoms which may not be related to cough at all, but might be related to changed oxygen carbon dioxide perfusion in the lungs. Does it tell you about any particular clinical condition which we are using in terms of COVID these days? One particular symptom, one particular condition which we are talking about COVID related to oxygen saturation or desaturation? Yeah? Anyone? Someone
Pneumonia.
was saying pneumonia will lead to, but I am talking about something pertaining to oxygen perfusion. And we say some of the patients who
Shortness
do
of breath.
bad shortness of breath, that is dyspnea, but there is one condition known as happy hypoxia. Have you heard this name in relation to COVID? If you're not, just note it down and Google it. Happy hypoxia. Normally, if someone is having hypoxia, that means less of oxygen, what do you expect to happen? Will he be happy? No. He'll be distressed. He'll be uncomfortable. But in COVID, there is a situation which is called as happy hypoxia, when the oxygen saturation actually goes down, but patient doesn't realize it. And suddenly it can lead to respiratory failure and severe conditions. So happy hypoxia is a manifestation in COVID. Note it down, find it out. It's very interesting. what will determine whether there will be infection or no infection primarily, and if there is an infection, what role it will take, what will be its effect, depends on a number of factors. First and foremost is anatomical. An infection in the nose, rhinitis, may have lots of discomfort, running nose, suk all the time, maybe lots of sneezing, maybe suffusion of the face, maybe headache, so many other things, but may not actually threaten the life. While on the other hand, a pneumonia or a pleural effusion can lead to sudden death also. So anatomically, which part of the body, which part of the respiratory tree is involved determines to a great extent the clinical features, the severity of the disease, as well as the outcome of the disease. Second is physiological. People where they are precariously balanced, like someone who is already suffering from chronic lung infection or chronic renal disease or chronic liver disease or severe uncontrolled diabetes mellitus, all those physiological conditions will also influence the outcome and the clinical features of respiratory tract infection. The changes in the physiology which occur because of the respiratory tract infection, like reduced perfusion, inability to sleep. Someone who is coughing whole night is not able to sleep properly, does not get enough rest, so becomes irritable. His mental functions deteriorate and rest of the bodily functions also deteriorate. So physiological influence could be based on a respiratory tract disease manifestation on the other systems, or it could be the other systems involvement which can affect, influence the outcome of the respiratory tract infection. One of the most important factors which plays role is how much is the local resistance to the infection. Respiratory tract is one system of our body which is constantly bombarded by billions and trillions of microorganisms, chemicals, dust, pollens, particulate matter, smoke, and so many things throughout our life, 24/7. The only time it stops is when you can hold breath. And how long can you hold breath? Maybe 30 seconds, maybe 40 seconds. There are some people who can hold breath up to 6 minutes and 7 minutes. Someone who just now broke a record by holding breath for 7 minutes. Any guess? One famous Hollywood actress broke a record of a famous Hollywood actor. By holding breath for a minute longer than him. 7 minutes. Earlier record was 6 minutes. But that is only after huge training. So who was that actress and who is that actor? Okay, for you to find out. Something to keep you busy. And there is a very beautiful movie which is being shot, which we are eagerly awaiting, and that particular sequence occurred during shooting of that particular movie. It is part 2 of the existing, one of the blockbuster Hollywood movies. So find out what movie it was. So physiologically, it will change. Now, local resistance factors will influence what is the outcome. In the upper respiratory tract, the resistance factors are very different from the lower respiratory tract. We'll see each one of them separately. Primarily in the upper respiratory tract, is the volume of the air which is going in is large. The apertures are big, the pressure is low. But as it goes down, the narrowing of the respiratory tract occurs, the resistance, physical resistance increases, the volume of the air gradually decreases. That is one physiological factor which is happening in the respiratory tract. And based on that structure, the local resistance also has developed. The epithelial lining of the upper respiratory tract is entirely different from the epithelial lining of the lower respiratory tract. The functions which they perform are entirely different, and therefore the resistance which they offer is very different. The local flora of the upper respiratory tract. Incidentally, there is no well-known local flora of the lower respiratory tract. That means most of the organisms are stopped at the level of larynx. They're not allowed to go below. But upper respiratory tract has got billions and billions of types of microorganisms, viruses, bacteria, fungi, everything, which by themselves have a huge influence on whether the infection will occur or will not occur. If the local flora is prominent enough, strong enough, it will not allow the pathogens to come and anchor over there. But if the local flora is disturbed by any reason, maybe use of antibiotics, maybe local application of antibiotics, or maybe steroids or anything else, then perhaps the invading organism can enter much more easily. The immune status, yes, both. The innate immunity as well as adaptive immunity play a big role. In fact, in preventing upper respiratory tract infection, it is the innate immunity which plays more role. Innate immunity, with the help of a local flora and with the help of local anatomical physiological structures, it throws away most of the microorganisms which are trying to cause infection. The immune status of the lower respiratory tract is entirely different. Innate immunity does play a role over there, but much more important role is played also by the adaptive immune system. So we need to know if there is deficiency in innate immune system, what is likely to happen? If there is deficiency in the adaptive immune system, what is likely to happen? And how, by various mechanisms, we can boost our innate or adaptive immune system and prevent disease. Can anyone give an example of any boosting of immune system which will prevent infection, a respiratory infection? Some example? Can anyone think of any method of boosting immunity to prevent infection by the pathogens of the respiratory tree? Any guess? What do we do to boost immunity? Yeah, go back to your first semester classes, some of the classes which I have taken.
So immunization.
vaccine.
Yes, vaccines. So can you mention any vaccine which is given to prevent respiratory infection? Okay, so that's a question for everybody. Make a list of the vaccines for prevention of infections of the respiratory tract. Make the list of vaccines which are used to prevent a respiratory tract infection. Any big study which is going on to prevent one particular respiratory tract infection by giving vaccine?
For COVID.
Yeah, yes, for COVID. So many billions of dollars are being spent to find out a vaccine which could be useful. And there are many other diseases which are prevented by vaccines. So find out what they are. Next comes is environmental factor. A great extent of damage to our respiratory tree occurs by environmental factors. By the temperature, by humidity, by dryness of the air, by the pollution of the air, maybe smoke, maybe particulate matter, maybe other chemicals, maybe exhaust from the internal combustion engines of the taxis and the cars and the buses and the scooters, or smoke coming out from the chimneys of the factories, or the pool being burnt. You know what is pool? Pool being burnt in the fields, which leads to a lot of smoke. So many environmental factors will influence our physiological condition and the local flora, and thereby influence the local resistance, immune system, and will predispose us to respiratory tract infections. So when you are taking history of a patient, you need to definitely ask about what type of a place the person lives in. Is it crowded? Is it not crowded? Is it air conditioned, non-air conditioned? Is it exposed to sun? Is it exposed to smoke, dust, and so many other things? And also personal habits which can influence environment, like smoking. One big factor leading to respiratory tract infections. So which are the different agents which can cause the respiratory tract infection? Well, all types of microorganisms can cause infections, but some of them are obligate pathogens. That means if they enter our respiratory tract, they will definitely cause disease. An example of them is Mycobacterium tuberculosis. Another example is plague bacillus. Another example is smallpox virus. So these are obligate pathogens. That means if you find them in the respiratory tract, be sure that they are going to cause damage. There are some pathogens which are called as secondary invaders, mostly bacteria, sometimes fungi, which are not primary pathogens, but they can come and enter once the epithelial tree is damaged, mostly by viral infections. So influenza, common cold, leading viral infections of the respiratory tract will damage the respiratory tract and make it predisposed to bacteria which are present in our oral cavity, etc., to come and cause infection. So these are called as a secondary invaders, which by themselves will not cause disease to start with, but in a disease process they can play a big role. It's actually presumed that the majority of the deaths which occurred due to influenza in 1918 and 1919, about 101 years ago, because of pandemic of influenza, were not because of the viruses, but because of the secondary bacteria which caused infection of the lungs. And one important bacteria was Haemophilus influenzae. The name influenza came because it was found to be invading patients who had suffered from influenza. And for many years, it was considered to be the cause of influenza till it was proved that it is a bacteria, not a virus, and it does not cause influenza, but the name is stuck, Haemophilus influenzae, as a secondary invader. If the people have low immunity, then there could be non-pathogenic organisms which can also become pathogenic, what we call as opportunistic pathogens, particularly in patients who have got immunodeficiency diseases, or patients where the respiratory tract has been damaged to an extent where that normal local flora or normal immune system or normal resistance mechanism cannot be effective. Then they become susceptible to opportunistic pathogens. Usually, there is only one type of pathogen which causes infection at one given time. One sword in a scabbard. You cannot keep two swords in a scabbard normally. But sometimes, particularly if the people are immunosuppressed or if there is structural abnormality, there could be multiple organisms, more than one type of organisms, which can cause a respiratory tract infection. Not a very common situation. Usually one type followed by secondary invader, but sometimes more than one pathogens can also cause disease, but not very common. So don't depend on that diagnosis very often. Try to make a diagnosis for a single organism infection. For the upper respiratory tract, if you just do a simple experiment, breathe in and breathe out and try to find the temperature on the back of your farm. What is the temperature of the air which comes out? Or is it warmer? It's warmer. Upper respiratory tract manages the temperature. It lowers the temperature if there is a hot air coming in. It raises the temperature if there is a cold air going in. And so this temperature change variation is also a type of host defense mechanism. But if the organism manages to live at the temperature at which our body inhales the air, it can overcome that particular defense. Lots of mucosal secretions which keep on coming into our nose, in our oral cavity, through the sinuses are the host defense factors. That mucus is trying to capture, entrap the pathogens into that and then throw it out along with our sneezing or with our blowing of the nose or with our coughing or secretions which get swallowed and going into the stomach. So mucosal surface and the mucus secretions plays a very big role, and on the mucosal surface is also present IgA antibodies against specific pathogen. Now here the mucosal surface is acting as a non-specific or innate immune system, while IgA is a adaptive immune system which plays a role over there. In addition, excuse me, other parts of innate immune system, that is the inflammation, phagocytes, neutrophils, all those cells are constantly coming into our nasal cavity, epithelium, into the mucosa, in the sinuses, and from there capturing and taking away the pathogens. In the lower respiratory tract, the primary role is played by ciliated epithelium. The epithelial lining which has got cilia, which keep on moving from below upwards and which keep on throwing the pathogens, dust particles, any particulate matter out of our respiratory tree. Inflammation also plays a part in the lower respiratory tract, and also some amount of IgA, some amount of inflammation, some amount of phagocytes also play a part, but most important part is played by ciliated epithelial cells. Like anywhere else, the way in which the organisms cause infection is, first and foremost, they must enter. So they must enter through our nose or through our oral cavity. These are the two entry points. Sometimes they can come through the lacrimal duct also and enter into our respiratory tree. Once they come inside, they must find a suitable cell which has got a receptor on which it can attach, particularly for the viruses. You must have heard that the coronavirus has got receptors which get attached to the ACE2 receptors on our epithelial cells. Similarly, most of the viruses have got one or the other molecule on our cell which they identify as a receptor, and they go and get lodged into that. You can say something like a designated parking place for the viruses. Some bacteria also have that property, but bacteria more or less don't get attached. They just stick onto the surface. They don't need a particular receptor. They just get attached by their size. They may get stuck with the mucus. Well, the viruses need a receptor to enter. Virus will go inside the cell and will start causing its damage. So once it goes inside the cell, it may destroy the cell, it may modify the cell, it may break the cell and come out in multiple copies and then again invade adjoining cells. So it can cause structural damage to the epithelial lining. While some of the other microbes produce toxins locally, bacteria, they do not go anywhere else. Once they have come in contact with the respiratory epithelium, they are lazy bums. They just stay there. They don't go out anywhere. But they produce toxins, and those toxins diffuse locally or may get into bloodstream, go into circulation, and can cause problems. Some of the bacteria resist phagocytosis. They can go inside the phagocyte, survive over there. They can get inside the macrophage, survive over there, like Mycobacterium tuberculosis. It can survive inside the macrophages. Streptococcus pneumoniae, because of its capsule, it can survive inside the phagocyte and does not get killed. On the other hand, it may destroy the phagocyte or the macrophage, burst open and invade other cells. So resisting the phagocytosis also is an important part of pathogenesis. Because of cell destruction, because of rupture, because of the local invasion, because of the toxin, lots of chemical modulators are secreted which initiate an inflammatory response. So the neutrophils may come, the polymorphs may come, eosinophils may come, monocytes may come, basophils may come, lymphocytes will also come, and all of them will try to capture the pathogen and destroy the pathogen, or capture the cell which has been destroyed by the pathogen and eliminate that cell from there. And all this activity, along with inflammation, leading to edema, leading to redness, leading to swelling, leads to tissue damage. In acute inflammation, it can lead to acute tissue damage. In a chronic inflammation, it can lead to chronic tissue damage, as in tuberculosis. And that chronic inflammation can lead to repair mechanisms, where there could be fibrosis and scarring. So one respiratory tube which is straight and very nice and smooth from inside may get strictured, may have a fibrous band over there, may have an indentation. There may be structural damage occurring to the respiratory tree or to the alveoli, and that will hamper the normal functioning of the respiratory tract. So that's the pathogenesis, right from entry up to repair and overcoming it. How will a respiratory tract infection manifest? It depends on which site it has involved and does it spread contiguously or not. Like a respiratory tract infection of the upper respiratory tract can spread into the sinuses and can cause contiguous spread in the sinus, leading to sinusitis, or may go into the eustachian tube and cause middle ear infection, otitis media also. So just from a sore throat, one can get sinusitis or can get otitis media down the trachea, bronchus, bronchi, and can lead to pneumonia. So there could be contiguous spread from one side to another. And this is what requires us to understand the natural profile of the disease. That means when we say that on the first day of the infection, patient may say there is a redness of the eyes, there is heaviness of the eyes, there is congestion, there is irritation. Second day, patient may say there is some irritation in the throat, he finds difficulty in swallowing. That shows that from the conjunctiva, organism has gone in and has involved this. Third day, the patient may say he is having difficulty and pain in the neck, lymph node involvement. Or after 6 days, patient may have severe cough and respiratory distress because the organism has gone along the trachea, bronchus, bronchi into the alveoli and has led to pneumonia. So contiguous spread will determine what clinical features are occurring, and they may keep on progressing day by day. If you understand the clinical condition, if you understand the natural course of the disease, you can predict and tell the patient, today you are having a little bit of discomfort in the throat. If it is not treated properly, you might develop pneumonia. Sometimes there are multiple site involvement by the same infection. So one organism comes and gets attached at various sites and can cause multiple infections. Sometimes the organism may get into the bloodstream and spread to distant regions. Now, one interesting thing happens is the respiratory tract infection or ear involvement can lead to meningitis, spreading from respiratory tract, which is open to the environment, to the central nervous system, which is closed from all sides, which is a sealed compartment. So they can happen like that, or can spread from there into the liver, or can go to the kidneys, or can go to other parts of the body and cause distant infections or distant spread of the infection. Since infection is associated with inflammation, there will always be systemic effects of the infection and inflammation. And the common systemic effects are fever, pain, malaise, loss of appetite, headache, not feeling well, heaviness, lethargy. All these systemic effects are as a result of inflammation occurring in the body. The site of inflammation could be the respiratory tree. So now let's have a look at actually the infectious agents. Up till now we are talking about how the infectious agents can cause problems. Now let's look at the infectious agents. In other words, let's look at your syllabus. So your syllabus for microbiology is posted over here. Viral upper respiratory tract infections, which includes variety of viruses, not only COVID, but rhinoviruses, adenoviruses, influenza viruses, etc. Pharyngitis and tracheolaryngitis, which can be caused by viruses as well as some of the bacteria also, like Streptococcus pyogenes, Corynebacterium, sometimes Neisseria, and many viruses, including all of these viruses. Epiglottitis, infection of the epiglottis is commonly caused by Haemophilus influenzae, while bronchitis is commonly caused by Bordetella pertussis, which also causes what is known as whooping cough. There are many more things, many more viruses can cause bronchitis. So you need to make first an anatomical diagnosis, which site is involved, and then based on this list, you can predict if it is rhinitis, it could be one of these four important viruses: rhinovirus, coronavirus, adenovirus, or influenza virus. And then depending upon the clinical profile, to quite some extent, you can say which particular virus infection is likely to be happening. Similarly, if it is pharyngitis, laryngotracheitis, these are some of the suspect pathogens. So, knowing about which site is involved by which particular organism, we can predict and then we can direct our treatment. Like there is no need to take any antibiotics if someone is suffering from common cold. A common mistake done by many clinicians that someone is having running nose, sneezing, headache, along with the antipyretic, give some antibiotic also. Not really required. They will actually cause more damage than the benefit to the patient. That was about the organisms which cause local infection in the respiratory tract. Now here is the situation. The respiratory tract is a way by which our body communicates with the exterior by exchange of air. And therefore, the respiratory tract can become an entry point for a large number of organisms which may have effect in the respiratory tract or may have effect all over the body. They might just enter from nose or throat, but will spread to rest of the body and will cause manifestations. So, systemic diseases which begin in the respiratory tract are measles, mumps, smallpox, chickenpox, influenza. All these are viruses. Meningitis, as I mentioned, bacteria may enter through the nose and throat, but may actually go into the brain. Commonest is Neisseria meningitidis. Sinusitis, we already talked about, and middle ear infection, and pneumonia also can be something which starts as an upper respiratory tract infection, but can progress to pneumonia. The agents which cause lower respiratory tract infection are slightly different from those of the upper respiratory tract. But some agents are common, like you will see Streptococcus pneumoniae. It is common both in upper and lower. Influenza virus can cause upper as well as lower infection. But tuberculosis will cause only lower respiratory tract infection. So is Legionella, Mycoplasma, most of the staphylococcal infections or other bacterial infections, cause lower respiratory tract infection, because in the upper respiratory tract there is local flora which does not allow these organisms to come and lodge in. So these are viruses, bacteria and fungi which can cause lower respiratory tract infection. So you have got now your syllabus for upper and lower respiratory tract infections. We'll be looking at how to investigate a patient with a respiratory tract infection, but just remember that the specimen which we'll collect will be the local most of the time. If the organism has stuck onto the epithelial cell and formed a membrane over there, we may peel off the membrane and use it for testing. Or sometimes we can take a biopsy of the tissue to see what organism is causing, and sometimes even the examination of the serum can give us a clue for organism which is causing disease. Example is COVID. You can take the serum, you can check it for the presence of antibodies or antigens and say whether the patient has got COVID infection or no COVID infection. How do we collect this? Yes, someone wants to ask something? Does anyone want to ask any question? Okay. How do we collect? The local secretions are collected on the cotton swabs, or the local secretions are aspirated by the syringe, etc., and these are called as the washings, or we may put few drops of saline onto the nasal mucosa or in the throat or in the lungs, wash it and take it out. That is called as a washing. Sometimes we may scrape the mucosa, or sometimes we may aspirate the fluid from maybe sinuses in case of sinusitis. So these are various specimens and methods of collection of specimen for upper respiratory tract infection. Similarly, for lower respiratory tract, we collect sputum or other secretions like bronchoalveolar secretions. We may take a tissue biopsy, or we may take a pleural fluid, tap the pleural cavity and draw some fluid from there. Or we can even collect a blood sample and serum sample to diagnose, because many times the organisms which cause lower respiratory tract infection get into the bloodstream and can cause bacteremia or viremia also. Methods of collection are more or less same. Active sputum, that means patient is asked to bring out the sputum, not the saliva, but the sputum which comes from the lungs. Or we can put an endoscope and aspirate the secretions from there if the patient is not able to cough, if the patient is comatose or semi-conscious, or we can take the bronchial washings or a biopsy, or as I mentioned, we can draw the fluid from the pleural cavity. So these are the ways in which we can collect specimen, and these are the list of specimens which we can collect. And how do we do the laboratory diagnosis? Same four principles of laboratory diagnosis: demonstration, isolation, immune response, and histopathology. We had looked at these principles of laboratory investigation of any disease in the first semester. We'll be following the same principles, and we'll talk in detail about them in the next class. How do you treat respiratory tract infections? Most of the infections require some or the other symptomatic treatment. If the patient is having a running nose, you need to give something which will stop the running nose. If the patient is having cough, you need to give something which will suppress the cough. If patient is bringing out sputum, you need to give something which will help him into bringing out the sputum or will suppress his cough. So these are symptomatic. Patient may have fever, you may be required to give antipyretic. You need to give specific treatment based on which microbe you are expecting to cause the disease. Antimicrobials, antibiotics are very widely prescribed for respiratory tract infection. About more than 60% of them are waste. Not only waste, but harmful to the patient, because more than 75% of the upper respiratory tract infections are caused by viruses. That means if you give antibiotic, you are likely to be treating only 25% of the times. Not good enough to pass the exam. Antivirals are useful but not always available and not always required, because antivirals have got their own side effects as well, like the antibiotics have. The antibiotics, in fact, may predispose the person to another bacterial infection also. Depending if you are suspecting some fungi to have caused infection or a parasites to be the cause of infection, we can give antifungals or antiparasitic infection agents also. But it all will depend upon how well you have been able to diagnose the disease agent, etiological diagnosis. And then, of course, the supportive treatment. The patient may have low oxygen saturation, may require oxygenation. Patient may have renal failure, may require management for that. Patient may have cardiac failure, may require management for that. Patient may be anemic, you might require to supplement that over there. And so many other things will be required based on other clinical features which could help in management of the patient, in getting the patient better. So that's the basis of treatment. Pharmacologists will be telling you about various groups of pharmaceutical agents which can be used for these purposes. How do we prevent? If environment around us is healthy, if it is free from microbes, we will not get infection. Basic principle of COVID prevention. Personal hygiene. Don't allow the microbes to enter your nose and throat. Use masks. And as and when possible, wash your hands. Don't touch your hands to your nose and oral cavity. You will not get infection. 90% of the times, we get infection in our nose and throat through our hands, not through the air, mostly through the hands, because our hands get contaminated and then we bring our hands close to the nose and then we rub the nose, or maybe put our finger inside the nose, or we just wipe our face with our hands and we inoculate those organisms onto the face, from where with deep inhalation they can get inside our respiratory tract. So personal hygiene, hand hygiene, masks are very important. Stay in an environment where windows are open, where doors are open, where there is a free ventilation, not in a closed environment where windows, doors are closed, where there is less air exchange. More air exchange, more dilution of the organism, less chances of infection. And of course, under specific conditions, we can take vaccines which will protect us against specific respiratory diseases. And that is one of your homework, to find out list of vaccines which prevent particular respiratory infectious diseases. So that brings us today to the introduction of the respiratory tract infection. We have seen what are the infective agents. We have seen how they enter. We have seen what factors influence whether infection will occur or not occur, which factors will influence whether the infection will lead to disease and the severity of the disease or not, how we can diagnose the disease based on clinical features, mostly listening to the patient's complaint, listening to the patient's respiratory sounds, and examining the patient can be of great help. And then we also have seen how we can do some laboratory investigations to diagnose, and once a diagnosis is made, treat with the specific antimicrobials, with supportive and with symptomatic treatment. So that's all for today. Do you think the studies are annoying you? Do you think you are being overloaded by studies? Even during your Diwali vacation, giving you homework and giving you exams, do you think it's too much for you? Well, you are amongst the lucky guys who are sitting in the most convenient, comfortable environment and studies compared to this, and they still want to study. So let's not lose the sight of studying. Keep on studying, keep on learning. It's a once in a million opportunity which is given to us to be able to study these things. Let's not waste that. That's all for today. Any doubts, any questions? Feel free to ask me. I'll be happy to answer any questions if you have, or if you come across some doubts, you may ask them in the next class also, or any of the subsequent classes, or you can post something. Any questions? Any doubts? No doubts? So you got some homework to do. One, some of you have already done is cervical lymph nodes. Next was about the pathogens and the vaccines, and some other things which I asked you to find out. Who can hold breath for 7 minutes, and whose record she has broken, which was a 6-minute record. And how you also can develop respiratory techniques of effective breathing, what we call as pranayam. Very effective breathing techniques, very important. If you have time and inclination, look into those and practice those. You'll realize how much difference it makes in your performance if you have got healthy breathing habits. So we stop here.